the next part of our meeting is going to be small group reflection.
We'll get started again. I'm Adrienne Paul. I'm a neonatologist at the University of Vermont Medical Center, faculty on the ICON team. And for this presentation, I will be co-presenting with Molly Rideout.
And I'm Molly Rideout. I am a pediatrician and pediatric and newborn hospitalist at UVM Children's, also faculty on this VCHIP ICON team. And we're excited to talk about this new Academy of Breastfeeding Medicine guideline that just came out, as well as the guideline that we've developed at the UVM Children's Hospital. And we're happy to share any of our process and copies of anything if folks are interested in, developing at your own hospitals. And next slide. I'm not sure who's sharing. Oh, here we go. So our objectives today are to explore this updated protocol from ABM, to talk about our clinical protocol, and to share a handout that we made. So we're going to start with a case. And this is great that Dr. Schiff, kind of like set the stage for our talk. This case, we have two cases in our presentation, and they both are cases that have happened at the hospital in the last couple of months. This one is a 19-year-old woman who had a healthy baby. She had heavy alcohol use in her first trimester, and also daily tobacco and marijuana use. She had cocaine use, buprenorphine use, not prescribed. Until the third trimester, she started medication for opioid use disorder, and she's currently stable on this treatment of buprenorphine. She did have an instance of cocaine use once during her third trimester. She did tell her provider about this. And then a urine screen at delivery for this mother was positive for buprenorphine and cannabinoids. Infant is healthy with no clinical symptoms of anything. So she wants to breastfeed. And what will you tell her? So just think about that for a second. And then also think about what will you tell them, the nurses or whoever's asking about in terms of toxicology screening for the infant. So hopefully you all know, maybe not, for our last session. So we're going to go back a little bit in time because the recommendations from Academy of Breastfeeding Medicine have really evolved over the last decade or more. So if we think about the case that we just had in respect to these guidelines, so really way back, there was so much, I mean, there's still a stigma, but like the stigma was really built into these guidelines, and things were really framed in a very negative way in terms of they referred in the guideline to infants of drug-dependent women and at risk for all sorts of problems. And then also even for women or birthing parents on treatments for opioid use disorder, they really at that time were saying that just there wasn't data to support recommendations for breastfeeding. So even if someone was on treatment, they really were recommending, caution. And they really discouraged it if there's any positive toxicology at delivery or relapse within a month of delivery, or if a person didn't receive prenatal care. So things have changed. So if we overlay that case over these recommendations, really this woman or birthing parent, which would have been discouraged from breastfeeding because of the marijuana, and also because caution because she was in treatment, and she had her instance of cocaine use. So moving forward a little bit, these are the recommendations that Dr. Schiff was referring to from 2015 from the ABM, and things shifted. And for women or birthing parents in treatment, they were encouraged to breastfeed. So that was a huge shift. but still cautioned for relapse within 30 days of delivery. And also cannabinoids or marijuana was, there cautioned, that was a shift, that wasn't a kind of a red flag anymore against breastfeeding. So if we overlay our case on this, kind of evolving, that it wouldn't have been kind of a green light for breastfeeding, still would have been some caution. I think I know in Vermont, we're kind of fortunate to live in a state that has been taking a lot of the guidelines with some grace and really realizing the importance of universal breastfeeding and interpreted. Some states have been interpreting guidelines very strictly and would taken up for these like middle of the road unsure portions of using caution would have come down hard against it. But in Vermont, we have tended to come down on the more encouraging side of breastfeeding. So I think even in this last version of guidelines, this person would have been encouraged to breastfeed. But looking at the previous version of the guideline, there would have been some caution because she didn't start treatment until her third trimester and she had an instance of cocaine use. So moving ahead to now, this just has come out in the last couple of months. This is really encouraging for us. A lot of the main background for this guideline was really to eliminate bias, minimize inconsistencies, and really encourage breastfeeding for as many people as possible. I really like Dr. Schiff's slide about breastfeeding as a human right. There's just so many proven benefits of breastfeeding. We all know this. And, the transmission of substances through breast milk is just very small. And, this is just a whole new culture change, a whole new approach. So we want to eliminate subjective decisions on who we think looks like a person who would be exposed to substances or using substances. Because I could use a substance at any time. And maybe because what I look like, people might not suspect that. Maybe another person would be highly suspect of it just based on what they look like. And that's the goal here, is to try to eliminate that subjectivity. And, the decisions are complex. So basically, a goal is to support autonomy of individuals and giving all individuals information about, sort of the timing that it takes if a birthing person is, exposed to a substance, how long that substance takes to be eliminated from the breast milk so that they can make an educated decision, and to have a multidisciplinary team approach. And just based on the overarching principle that breastfeeding is recommended if a birthing person stops non-prescribed substances by the time of delivery, and that they should continue to receive ongoing like wraparound care. And that these decisions are usually quite complex. So the timing of initiation of breastfeeding is something that is pretty complex, given, if a woman or a birthing person has stopped substance use at the time of delivery, what's the timing of starting breastfeeding? And it really is shared decision making, and based on what the substance is that they they have taken, and so much is based on shared like communication with providers and with caregivers, because and that is a huge culture shift in terms of open communication. But if we can create that culture over time and build trust with patients, then we'll be able to rely on those conversations versus relying on the testing of infants, which is not reliable, and hopefully, support parents in autonomy. We know that over the last, few years, the rates of overdoses in the state have kind of skyrocketed. So we know that there hasn't been a decrease in the amount of use of particularly opioids among the entire population. But we have in the hospital seen fewer and fewer cases of infants exposed, noted to be exposed to opioids, but it's probably hidden because we know that there's been increased use. So there probably is increased use. So people most likely are not, reporting their use to providers. So that's kind of a trend that the goal is to kind of reverse that so that things are out there and we can have open discussions about it. But culture shift is hard and takes time. So this, yeah, so culture shift. It's important to support birthing parents in expressing milk, even if they aren't able to give that milk immediately to their infants, depending on the substance and the time it takes to eliminate it. So lots of lactation support, and then the decision of when to start based on what the substance is, given sufficient time for the substance to pass. And then just recognizing that postpartum use, either, relapse or even starting use later, even if a person hasn't used in the past, just using a similar approach, just recognizing that giving universal information to all parents so that they can know if at any time after the baby's born, they return to use or start use, they can know how to keep their babies safe. So just looking back at the original case that we looked at, overlaying the current guidelines, this would be green light for breastfeeding. The fact that the mother started treatment at all in the, third trimester is fine. And the fact that she told her provider about her cocaine use in the third trimester is great. So that's the goal, is open communication, shared decision making, making sure that the infant is safe, and having all of the information out there. So multidisciplinary support and a goal of open communication.
And so I am going to share how we have taken the new guidelines that just came out and adapted them for a guideline at the University of Vermont Medical Center. And just for background, we had a group coming together working on developing a breastfeeding guideline and working on establishing consensus and outlining what we wanted to put on paper as our standard. And this guideline came out at a perfect time for that group. And we were able to take this information and essentially reinforce it in our guideline. So again, the purpose is really to provide guidance for breastfeeding and birth parents who have recently used non-prescribed substances based on the updated recommendations from the Academy of Breastfeeding Medicine. And our rollout of our new guideline is this month. So it is already active. And I'm just going to go through the guidelines step by step. The first point that we make in the guideline is that breastfeeding should be supported in most infants, and specifically this includes infants whose birth parent is treated with medication for opioid use disorder, is prescribed opioids for pain, benzodiazepines for anxiety, or stimulants for ADHD, and who used non-prescribed substances during pregnancy but have stopped use prior to or at the time of the birth hospital admission. And this is using language that is very similar to the language that is in the ABM protocol. Some of it is truly copied word for word. There are rare contraindications to breastfeeding. And so we acknowledge those in our guideline, but we don't go into them in detail. And then we also acknowledge that there are situations with medically complex infants or infants in the neonatal intensive care unit setting where we may take a slightly different approach due to the medical scenario. Our second point is that breastfeeding is encouraged for infants during the first hour following delivery, or the golden hour, even if there was recent substance use reported or suspected. And this is not outlined in the ABM report. We decided this as a group, acknowledging that the goal of the golden hour is truly to promote bonding, and that the transfer of colostrum is likely a very low volume, and the amount of a substance that is within that colostrum is also likely incredibly low. And so we wanted to de-escalate that first golden hour so that the focus could be bonding. And then after the golden hour, there could be discussions and individualized planning. Our third point is about that individualized planning, and that it is recommended after the golden hour in partnership with the family and their care team to document expectations for breast milk provision during hospitalization and after discharge. And so this is where that multidisciplinary approach comes in, and the emphasis on conversation, communication, and individualization. Breastfeeding is encouraged for individuals who have discontinued or commit to not using non-prescribed substances while providing breast milk. And when recent use is reported within a week of delivery or toxicology testing from the birth parent is positive, then we have a table that can be used to determine how long, if at all, breast milk should be discarded to allow sufficient time for substance to clear from the system and not have significant exposure of the infant. Our fourth point is that birth parents should be supported in expressing milk to establish milk production, especially if they have recent non-prescribed use and will need to discard milk while awaiting substance clearance. Our fifth point is that universal lactation consults are recommended, especially for this population, to support that individualized planning, and recognizing that many birth parents with substance use histories will also have trauma histories, and a trauma-informed approach is essential to support their desired lactation choices. So we plan to prioritize lactation consults inpatient for families with known substance use history on delivery day and continuing throughout the hospitalization. And we will aim to establish referrals for community-based support through home visiting services or private lactation consultants after discharge. We also are recommending education for all families, so universal education about substance use and breastfeeding. And this will be provided with a standardized handout that can be given to families prenatally, during the hospitalization, that families can take home with them or after discharge. And ideally, it's standardized enough that everybody feels comfortable talking about it. So if questions arise, whoever is fielding those questions can pull out the handout and look at it together with the patient. For postpartum or later non-prescribed substance use, we recommend a very similar approach of expressing and discarding milk based on consultation with a multidisciplinary care team and based on the clearance time of the specific substance that was used to inform breastfeeding decisions. So I mentioned our table earlier. We created a table based on the half-life of different substances, like Dr. Schiff mentioned. And we categorized substances as short-acting, medium-acting, or long-acting, depending on whether that period of 5 half-lives would occur during a 24-hour period, 48-hour period, or longer. And so for short-acting substances, those are substances that generally clear from an individual's breast milk by 24 hours. Medium-acting substances generally clear by 48 hours, and long-acting substances are a little more variable, and we recommend individualized discussion. One important thing to recognize is that clearance from the bloodstream may not be the same as clearance from the breast milk. So there may be slight differences there as you get into the literature. And we didn't outline that in our guideline, but I think it's important for everybody to acknowledge. This is our reference table. And so you can see The top has short-acting opioids and stimulants. The middle has medium-acting opioids and stimulants. Towards the bottom, there's longer-acting opioids and benzodiazepines. And then at the very bottom, we also included other substances such as alcohol, cannabis, and nicotine, since there are often questions about those substances as well. We also acknowledge that this is not an all-inclusive list, that there are emerging substances that we may not have sufficient information to include in this table, and that as new evidence arises, that we will adjust the table accordingly. And Dr. Schiff mentioned fentanyl. We have categorized that as short-acting based on its half-life, and have recommended a 24-hour clearance for fentanyl. But this is an example of something that we will reach out to Dr. Schiff and explore a little bit further to see if we need any updates to this. This is a screenshot of our universal patient handout. And you can see it has a lot of information. We have included information on alcohol, nicotine, cannabis, opioids, stimulants, and benzodiazepines. And we have included both the infant effects that may be noted, as well as specific details and recommendations about each substance. And the goal with this universal handout is really to acknowledge that use can happen at any time, and that we may not know if a patient has substance use in their history or in their future. And as Molly mentioned, we are seeing fewer identified infants with substance use exposure. And yet across the state, we know that substance use is continuing, and if anything, maybe increasing. And so there are a lot of families that we likely are not identifying as having substance use. So this is an attempt to provide full information to all families for informed decision-making, encourage collaborative decision-making, encourage conversations, reduce stigma, make this something that's really just okay to talk about anytime. So with that background about the new guideline at UVM, about the new ABM protocol, we're going to go back and talk about another case that happened recently, where we used this new approach. So it's a healthy term infant with a normal physical exam. The maternal toxicology on presentation was positive for cocaine and THC, and the mother reports cocaine use a week ago. She endorsed this. So the toxicology aligns with the history. She said that this was a slip up, denied any opioid or other substance use. She didn't breastfeed during the golden hour and was planning to formula feed. However, in the subsequent day, the infant started rooting, and the mother wondered about breastfeeding. So same question as the first case. She wants to breastfeed. What will you tell her? And a similar second question. Will you recommend toxicology screening for the infant, or testing, we should say? So with this new guideline, our team would support breastfeeding 24 hours after the last cocaine use, with an emphasis on exploring resources for continued support after discharge. This is a situation where we want to make sure that this mother feels very well supported, has resources, and has open lines of communication should there be future use, to make sure that her infant does not have an exposure. And then in terms of toxicology testing, we know that there is cocaine exposure within a week prior to delivery. We know the maternal toxicology test was in alignment with the maternal history. Infant toxicology testing would not change medical management. It's unlikely to add new information, and so we would not recommend it in this case. So just as a summary of everything we've talked about, There's a new Academy of Breastfeeding Medicine guidelines that aims to facilitate breastfeeding and minimize inconsistencies and bias. UVMMC has adopted a breastfeeding guideline for infants exposed to substances that aligns with this new ABM guideline. And the key components of the UVM-based guideline are that the golden hour is preserved for bonding, given that there's minimal transfer of colostrum. Breastfeeding is supported after a substance has cleared. Individualized care planning for lactation and recovery support are essential. And we are implementing a universal education approach with a handout for all breastfeeding parents about the best practices for human milk and substance exposure. And this is a list of some of the people who were involved in developing the UVMMC based guideline. So feel free to reach out to any of us if you have questions, comments, or would like to see our material. And I think that we have a few minutes for questions before we move on to our next talk. Again, feel free to raise your hand and unmute yourself or put questions in the chat.
And I'll just summarize, there's still active conversation going on in the chat if folks haven't been following it, but just it's about fentanyl and it's about xylazine. So in terms of fentanyl, just the use of fentanyl often in the course of delivery and how, but LactMed really states, and I didn't look into their references right now, but just that when there's a difference when it's used for short procedures. So it doesn't need any different management. And also we can definitely share any of the handouts. And another question about xylazine. We just don't have information yet, like Dr. Schiff was saying, and we definitely will incorporate once we do, because it is really crucial and very common, and lots of open lesions, particularly on the extremities with xylazine. And then just, of course, important to use all the usual precautions in terms of HSV lesions, keeping those away from direct contact with the baby. And I think those are all, and we'll keep folks updated. We'll definitely investigate more of the fentanyl, because that was a little bit different from what we had in the guideline, and it looks like it was different from what another individual said that was their understanding. So we'll dive into that and update that in statewide, network-wide meetings. Yeah, Jennifer.
Thank you for this work, and I hope that it will all be able to be shared and also trickle down to those of us in the UVM Health Network to be shared across the system, for standardization. That would be really helpful for our teams. I continue to be confused, even though we've had many trainings and discussions, and Michelle actually even consulted with our clinical director around reporting for use in the third trimester. And maybe I'm missing something. I know it is very confusing, but I continue to be confused about that. So I have questions around that as well. And I had a more recent situation where I did choose to call for someone who did report to us about cocaine use in the third trimester. And obviously the trust and relationship building, and it was emotional and was difficult. And so we're swimming around in these waters still. I know it's not cut and dry, but any recommendations that you're swimming around into, I guess.
Michelle, do you want to take that? Yeah.
Yeah, I'd say we're continuing to work with our Department of Children and Families, Family Services Division colleagues to really talk about the way that our open cases and reports are made and what happens in regards to those. I think one of the things that I'm trying to recommend to people is there's a really nice model of having the family self-report with you. So that is a way to continue to have the family involved and have them have the power of telling their actual story to DCF at the time of even the report. and not waiting for, is it going to be opened? Is it going to be investigated? Is it going to move on from there? So that's one strategy for now, until we work with family services to come up with a different procedure. It's still considered something that you would make a call for. And I always want to make people aware of that. That doesn't necessarily mean because you make a call that an investigation will be opened. So that's another thing just to sit with the family. This doesn't mean there's going to be an investigation. They're going to look at lots of information. You know, and the whole point is to get you some extra support before the baby is born. So it's not a knee-jerk reaction, is what I was just talking with some of the national teams about, where in other states that would be a report at the time of delivery. So framing how we talk about it. We still have to do it.